What's up, y'all? Welcome back to another episode of In the Wild. I am your host, Rayshawn, and today we have a very interesting topic that we're going to talk about. Well, two topics. We're going to talk about maternal health and also rural health and how just Georgia, for those that are unfamiliar, has very high maternal mortality rates, especially for Black women. And so for today's episode, we're going to talk to two professionals who are helping address that issue. So we have Dr. Marlo Vernon as well as Dr. Catherine Clary to bring in their expertise to see what some of these issues are, but also what Augusta University is doing to help hopefully solve some of these problems in the state. So we got a very fun and interesting episode in store for you, even though it's a very serious topic. So I hope you're ready, Jag Nation, because here we go. Thank you both for being here. Welcome to In the Wild. So excited to have you both, Dr. Vernon and Dr. Clary. And to get started, could you both tell me a little bit about your background and how your roles kind of intersect with maternal health?
Sure. So I'm Catherine Clary, and I'm the Director for Rural Health within our School of Public Health here at AU. And I kind of have a different background in that I'm an attorney.
Oh, wow.
And so practiced law for a while in Atlanta and then moved to Augusta and started working in outreach for Augusta University Medical Center. So in that position, I was out in a lot of rural communities and really got to know people throughout Georgia, and then was brought on as the Director for Rural Health. And so within that capacity as Director for Rural Health, I really became interested in rural health in general, but also maternal health and women's health in rural communities. And that's how Marlo and I started working together, and it's just been a really neat experience.
And for me, I've actually worked at AU for 21 years now.
Okay.
I started as a research assistant on an obesity prevention project for children. My background's in public health. And just over the years, kind of worked my way up and then got my PhD in 2018 here in the Applied Health Sciences program. But maternal and child health has always been my passion and my field of choice. And particularly working to prevent low birth weight babies. But then as things transitioned in the state, I really learned about the terrible numbers we have as it relates to maternal mortality and morbidity. Georgia is unfortunately at the bottom and tends to stay at the bottom. And there's a lot of great opportunities to improve that. And so that's where I have been for a long time.
And for those who are unfamiliar, what are some of the unique challenges that Black mothers may face when it comes to rural healthcare and just that sort of setting in Georgia?
I can speak quickly to the fact that, Marlo will definitely have more detail. I will just say that one thing, even without going into race, is the lack of Medicaid expansion in Georgia. And so because of that, a lot of mothers who may have been covered, not just in pregnancy, but for other health issues, are not covered. So that's just something policy-wise that there's an issue. But then Marlo has much more detail as far as...
Well, a lot of it has to do with access. Georgia has 120 rural counties out of 159 in the entire state.
I didn't realize that.
Yeah, so the majority of Georgia is rural. And of those 120 counties, 70% are basically a maternity desert. And what that means is women cannot get to a doctor who is trained to provide prenatal care or to do delivery care. And in the last 15 years, a lot of our rural hospitals have stopped doing deliveries. And so these moms now have to drive 30 minutes, 45 minutes, 2 hours to get to a delivery hospital and to get prenatal care. And particularly for Black women who are at higher risk of hypertension during pregnancy, diabetes, they may come into the pregnancy with not an optimal level of health. They may need to see specialty doctors. Specialty doctors are only in the major urban cities. And it's just really, it takes a lot of time for someone to travel to Augusta, for example. Then you have to make sure your children are taken care of, that you have time off of work, that you actually have transportation to get here. And then you basically spend a whole day waiting to see the doctor and then get home. And sometimes especially if it's not communicated very well how important these visits are. Women will skip them. And then we end up with just greater challenges in maintaining a good level of health during and after pregnancy. And I can speak a little bit to Medicaid in the state. 2 years ago, the Georgia legislature extended Medicaid. We didn't expand it, but we extended it for moms for the full 12 months postpartum. So in those situations, moms are able to see a primary care doctor, make sure they've got specialty care if they need it. They can go to the eye doctor, they can get dental care. But what we were finding, and what one of my projects really focuses on, is making sure that moms take advantage of those benefits. They don't really see their OBs after that 6-week appointment, if they even go to that 6-week appointment. And so we need to make sure that moms are aware and that they have access to those benefits that they can really utilize to have better health.
So what role does AU have in, I guess, just shaping that conversation statewide?
I mean, that's a great question. We have all of our regional campuses, and so we're well positioned to really be a force for good and change and increasing access for women as it relates to maternal and even women's health in general. I work with some of our family medicine doctors who have a real training and passion for maternal health, and they want to see more residency options and training for our family medicine doctors to provide this type of care in rural areas. Augusta, we have a cardio-obstetrics program here, which was recently instituted by Dr. Chad Ray and Dr. Sharma. That's funded through the Department of Public Health. And so that's one of the first in the state to provide, cardiology care along with obstetric care. So if a mom is diagnosed with hypertension, preeclampsia, cardiomyopathy, any type of cardiovascular concern, she's seeing not only an OB but also a cardiologist. And that program is going to be replicated across the state. And that was funded by the state legislature as well. And it's one half of our pilot program right now. The other half is my care coordination program, which is making sure that moms don't fall through the gaps and are able to receive that care during the first year postpartum.
And what would you say just the lack of access for those rural areas, how they impact the, I guess, healthcare outcomes for the mom and the babies?
Mm-hmm. Do you want me to?
Sure. I'm like, this is her passion. I will say that. So, no.
Well, when you have a mom who needs care and she's not getting it, or she doesn't feel like she has the availability or the access to get it, she doesn't feel well taken care of. And so then we start with a negative experience, perhaps, seeking care. Some of these moms go to the emergency room to deliver because they aren't going to make it to Augusta. And if those emergency rooms aren't equipped or have people in place who know how to do a birth, it can lead to negative outcomes. And that's one thing Dr. Ray and Dr. Matt Lyons have really started working on, is having tele-OB emergency services. Mm-hmm. So those emergency rooms can call into our regional perinatal center here at AU and have someone walk them through. We have a similar system for stroke care, and now we're implementing it for maternal care. But just really, making sure that you're being taken care of, that all of your measures are in line with where they should be. If you go to one prenatal appointment and your blood pressure's fine, but then, over the next month it starts to increase and no one's checking in on you, and then maybe you don't go to the next appointment, that can really lead to some serious negative outcomes, both for mom and baby. And when we talk about babies, they need to be seeing a pediatrician. They need to make sure that they're getting their developmental checks. Early intervention is key to preventing lots of long-term health consequences.
And Dr. Clary, for you, what are some other, I guess, healthcare disparities that you see from the rural side of things?
I think that there are a lot of disparities, whether it's insurance coverage that we were just talking about, but also something that Marlo talked about earlier is the distance to care, because there are no OBGYNs in most rural counties. And so it's that lack of having a physician in your county. And also, we used to, I say we, doctors were trained before for a general practice or family medicine physician to be able to deliver babies. And they are still trained to do that, but a lot of general practice physicians don't want to do that anymore, whether it's because of insurance or just feeling like they don't. And when I say insurance, I'm not talking about Medicaid or health insurance, but more malpractice insurance. So if something happens, that physician doesn't want to feel like, oh, I'm nervous about getting sued or having an issue. So I think those are some of the barriers to the old, country doctor who used to do everything from birth to death. And so I think that there are a lot of projects in place to improve that. As Marlo said, having some telemedicine to help those physicians if they are in a situation where they are delivering children, and also just giving them more capabilities as far as that prenatal checkup for mothers as well.
Yeah, hearing you say that makes me think of my own experience as a kid, because I grew up in one of the rural counties in Georgia that didn't have a physician. And it wasn't until I moved to Augusta and I started, taking care of my own healthcare concerns as an adult, where I was like, oh, it's normal for people to have a primary care physician, and it's the same person for a number of years or for a while. Because for me as a kid, I never had that one person that we would go to. It was always a different person. Like my county had a clinic that you would have maybe a nurse or someone to do things, but I never had that relationship until I became an adult. And learning all the stuff that I know from my primary care team now is like, oh wow, I wish I would have had a pediatrician when I was a kid that I could talk to and all that good stuff, because it definitely impacts you later in life as well.
Well, I may kind of go off on a tangent, but not a question you asked, but with that, it's the same with our medical students. If you're in a community where you don't know a doctor and you don't have a doctor in your community, I think that you're way less apt to think, oh, maybe I could go to medical school, or maybe I could be a nurse. Because I think that so many of us, we see what's around us. I grew up in a really small town, and I went to college, and I remember thinking oh, I didn't even know there were these careers.
Right.
And so I think that when you are in a rural community, that's another thing where we are trying to find students who are interested in medical school, so that they hopefully will go back to those rural communities where they came from. So that's something that is, as I said, I kind of went off on a tangent, but that just made me think about it. So.
Yeah, and that makes sense, because it's all connected.
Yes.
When people see certain careers, like you mentioned, that inspires them. We've talked to some dental students the other day to talk about when they had their first experience with the dentist, that just kind of connected and was a light bulb moment for them.
Yeah.
So that definitely does have an impact.
Where are you from?
I am from Montgomery County.
Okay,
Georgia.
Southwest.
Southeast, I guess.
Okay, what?
It's an hour from Macon, 2 hours south of Augusta.
Okay.
Sometimes I call it the middle of nowhere, Georgia, because it's
Yeah.
right in the middle of the state. But switching gears a little bit, I have a fun game for you guys, and you are actually the first to play this game.
Okay.
It's called Med-Win, Med-Sin. So I have some scenarios about maternal health that I want to get your perspectives on, and if it's good, you'll give it a win, and if it's bad, you'll call it a sin.
Okay.
All right, I'll pass one to Dr. Vernon for me,
Thank
please.
you.
Should we say something like, none of these opinions are...
Yes, these are your personal opinions.
They do not reflect Augusta University.
Okay, so first one is using a doula for support during pregnancy. Oh, that was quick.
Yeah.
Both of win.
And I would just say doulas are, a really great newly supported initiative across the state. And I really would like to see doulas who are trained and certified in some way so that we have consistent care.
I love that. Second up, driving over 2 hours to access prenatal care. Sandy.
That was the easy one.
Yeah, and I feel like you guys did a great job of explaining why that's so bad. Next one, I guess going off of the drive, using telemedicine for routine maternal checkups.
Yeah.
I will say, I've talked to a lot of moms across the state, and they still want to see their providers in person.
Okay.
So there's a bit of a cultural gap, maybe, where we need to find a good resting middle ground for moms to access that prenatal care.
Ignoring pain symptoms post-childbirth.
Definite no. But a lot of moms need to know what it is that they need to be watching out for.
That's true.
I can tell you that a majority of the maternal deaths that are reviewed by our maternal mortality review committee found that it was day 7 through day 60 that a majority of maternal deaths occurred in our state.
Oh, wow. Next up, reducing postnatal follow-up appointments to cut costs. Sin.
Yeah.
Okay. Partnering with public health programs to improve rural maternal care.
Definitely.
Yes.
Are there options for that currently here in Georgia?
Yeah, there's a new program, I think it's called Perinatal Home Visiting Program, that the state legislature is funding through DPH, our Department of Public Health. I think they just expanded it to 25 counties where they have nurses who will do home visits with pregnant and postpartum women, looking at a variety of risk factors and health outcomes. So it's expanding and it's a good thing, but there are more moms in need of programs like that.
Relying solely on emergency care for pregnancy-related health issues.
No.
No. That was also very quick.
Yes.
And last one, creating community-based health programs for expectant mothers.
Absolutely.
Absolute win. Yeah.
I think we're talking mostly about, I guess, physical health, but I think mental health is also very important for mothers. You know, I think it's
Absolutely.
obviously all intertwined, but
Yeah.
definitely I think community services can help support the mothers and with health and mental health.
Yeah. Mental health was actually the second leading cause of death
Oh, wow.
in the last Maternal Mortality Review Committee report. And that includes substance abuse as well as when you think of mental health, depression, suicide. So it's definitely an unseen issue that a lot of moms struggle with that they need support for.
Well, thank you guys both for being here, playing
Thank you.
MedSin MedWin.
Of course.
Any final thoughts before I let you guys go?
I don't have any
Yeah.
final thoughts.
All right.
No,
well,
I appreciate you having us here. This has been fun.
Thanks for educating me because there's a lot of stuff that I didn't know that I'm going to go. Hopefully, folks watching this will be able to carry on and make some better decisions.
Yeah, I will say if anyone's interested in learning more about pregnancy and moms, there's a lot of great resources on the internet. My program, Vita RPM, we have a website on the MCG page that provides a lot of health education and tools for self-monitoring for moms.
Well, thanks again. And for those watching, stay tuned because we got some more fun stuff coming up.
Stay connected and organized with My Augusta, the official app for Augusta University faculty, staff, and students. Customize your dashboard to view courses, emails, files, events, and more with easy-to-use widgets. Access personalized tools that give you access to other systems and apps at Augusta University. Pin your favorite pages and tools for quick access. Find exactly what you need: pages, tools, events, people, files, and posts with a simple search. Filter results to save time. Receive tailored alerts based on your profile and never miss important updates or events. Download and explore My Augusta today.
Well, welcome, Dr. AJ, to In the Wild, and thank you for letting us be at our simulation center today. For those who are unfamiliar, do you mind introducing yourself and your role, and what is our simulation center here at Augusta University?
Sure.
My name is A.J Kleinheskel. I'm the Assistant Dean for MCG Educational Simulation. We are a program that operates statewide, but today we are in the Augusta University Simulation Center. It's a beautiful center that hosts all of the different health professions education programs here. It's 40,000 square feet. We have outpatient clinical skills rooms where we use standardized patient actors to portray patients. We have high fidelity mannequin rooms that I believe you'll be highlighting as well as part of this. And then we have some skills space like we are in right now, and that allows us to portray the range of simulation necessary to educate health professionals.
So you have your career in simulation education, but for those who are unfamiliar, what would you tell them as to why having simulation education is important?
Sure. In the health professions, you never want the first time you do something to be with a real patient. Now, that could be using a needle, but that could also be delivering bad news. So whether you're talking about the psychomotor skills or you're talking about the affective domain of how you interact with and establish rapport with a patient, that takes practice. Especially when you're a novice learner, you're really focused on the what, you're trying to figure out all of the different steps. It's hard to then integrate the clinical reasoning you need, which can be a little bit more flexible and adaptable to each patient's situation. And so in this space, our primary value is going to be safety, because if you make a mistake here, there's no patient outcomes at risk. But there's also another kind of safety we have here in simulation, and that's psychological safety. And that's the idea that if you did make a mistake or a misstep, there's no both real world consequences or academic consequences. And so we talk a lot about how there's no shaming or blaming here. We expect people to make mistakes when they're learning something new. And if you are going to make a mistake, simulation is the absolute best place to make it, because we can debrief after the simulation and really figure out how you're thinking about things and unpack that so you never make that mistake again.
And I think that you make a great point about the psychological safety, because you're entering into this space and you know it's a safe space for you to ask questions, make mistakes, but at the end of it, like you mentioned, debrief and learn from it and grow from it.
We use a growth mindset here in simulation.
I love that. And the university has helped or invested a lot recently into this space. Do you mind talking about some of the advancements and improvements that
Absolutely. This is a very large space, so it is quite costly to maintain. I tell people all the time, simulation is very effective when you do it well, but it's also very resource intensive. And so we've been very lucky that in the past couple of years, we've had some even larger investments, both to replace some outdated end-of-life mannequins, but also to install a new simulation AV system, which allows us to do the monitoring of the space, recording things, the student assessment instruments, things of that nature for our higher stakes events. And so that's been quite expensive to install and deploy, and we're very, very grateful for it.
And what do you experience when students come in here and they're using the space for the first time? Like, what do you, I guess, hear from them and their feedback from having a space like this?
There's usually kind of a spectrum of responses. On one end, you'll have learners who are really excited because they get to apply what they're learning. It's one thing to sit and read about something or watch a lecture about something, or even do case-based learning. It's another thing to come in and try it, right, and apply what you're learning to see if all of those pieces are falling together. And so a lot of people love sim days because it's a fun way to learn. But then the other end of that spectrum, to be transparent, is a little bit of skepticism, right? Okay. Well, I just can't get into it. It's not a real person. And so that's where we come back in as simulationists and talk about what's called a fiction contract. So we say, we know that our patient today isn't real. We're not trying to trick you into thinking it is. But when you can suspend your disbelief and give an authentic performance of your skills and abilities, you're going to get better feedback from your faculty or your facilitator, because it's all about giving you feedback and helping you grow, understand where you are, but then also understand where you need to keep going. And so when you kind of frame the value that way and help them suspend their disbelief by acknowledging what is unrealistic and where you're trying to get them, most people then can buy in and kind of get going.
I love that. So what type of simulations can you guys facilitate here? Because I feel like you can do a little bit of everything.
Yeah, we maybe can't do everything, but we
Okay.
can certainly do a lot. I say that because there's some really specialized simulation, like surgery, for example. They have a Da Vinci robot simulator, and we don't have that here because we're not specializing in surgical simulation here. So this is more of a general space, but we can simulate adult mannequins, pediatric mannequins, we have a newborn baby, we have a preemie, we have an infant. We also have our standardized patient actors, which give us a range of ages and genders and ethnicities as well. And then we have task trainers, which are partial body parts. So we could run a case with an acute MI on an adult mannequin where they're, addressing that need immediately, or we could break that down into a skills workshop and just teach how to read the EKG or to listen to the heart sounds. So we have quite a wide range because you want to make sure your simulation is tailored to the level of learner. You don't start out with the high fidelity mannequin running a code, right? That's overwhelming. You have to kind of scale those things up so that they can learn the basics and then put them together. And so we try to offer a range, not just in the modalities we offer, but also in the learning domains. And so we try to do psychomotor, obviously, where you're learning to tie the knot, or you're learning to place the IV. But then we try to also do the affective domain, like I mentioned, delivering bad news, talking through goals of care with people, establishing therapeutic rapport. And so we want to make sure we're kind of covering all of the different important components of becoming a healthcare professional through all of the different modalities we have available.
So I ask a lot of people this question, and I'm really curious to hear your response. If you were given just unlimited resources for this space, what would you immediately add, or what would you do? If the money was no object, what would our simulation center look like?
That's a good question. Although I have to say we're so lucky to have this simulation center. I've been working in sim for quite a while, and this is probably one of the best centers I've seen. It's huge, it's great. We have a lot of different spaces that we can use in creative ways. I'm sure I could come up with a list of some more task trainers or different mannequins or things like that, but if honestly I could just have one thing to focus on, it would be more faculty who had the time, the dedicated time and ability to learn how to do simulation well, because it is a very technical way to teach. It's maybe not an intuitive pedagogy, and so giving faculty the time and space to really master the skill, and then give more of our students that one-on-one feedback and coaching that's going to help them develop their clinical reasoning and clinical skills.
That makes sense, to have more folks invested in
Yes.
simulation. I gotcha. And so we're about to experience our own simulation. Do you mind giving us a little overview about what we're going to experience?
Sure. So I mentioned we have some adult mannequins. Well, two of those mannequins are actually birthing mannequins. They're called Lucina. And Lucina is a mannequin that can simulate a range of births. So that could be a normal vaginal delivery, but it could also be a shoulder dystocia or other complications. One of the great things about simulation is that we can portray high risk, low frequency events. So these are things that our learners might not necessarily see when they're learning bedside, but it's really important for them to understand what to do if they ever do encounter that situation. And so Lucina is something that we can use to help portray some of the different complications that could happen during delivery.
Well, I'm excited. I'm super excited, and thanks again for letting us use this space today.
Very
Where
welcome.
can our listeners go to learn more about the Simulation Center?
Sure. So Augusta University has a website for the Simulation Center, has a little bit of information there. And then as we continue to develop our programs and incorporate other health professionals, I believe we'll be delivering other materials like in some of the faculty development spaces, some trainings there, and some databases of cases and task trainers and things like that, so people understand what we have available here.
Awesome. Thanks again, and I'm excited for what we're about to experience. So y'all watch and stay tuned, because we'll be right back. All right, y'all, we are back. This time we are in one of the simulation rooms with Mallory. Mallory, do you want to tell everyone a little bit about what you do here at the Sim Center?
Yeah, so I'm Mallory Cunningham. I am Director of Operations here at the Simulator Center. Been here for 5 years, and we run a full sim lab 5 days a week. We have several hundred students that come through every week. We have over 10 high-fidelity simulation rooms, and Lucina here is one of our high-fidelity simulators who is a birthing mannequin.
So tell us a little bit more about Lucina and all the things that she can do, because right now, I don't know if you guys can notice, but she's actually breathing right now.
Yeah, so she is interactive, and you can take a history and physical on her. So she will respond vocally through, obviously, a facilitator that's behind the glass. She also blinks. Her pupils will dilate.
Oh, wow.
She has breath sounds, heart sounds, and she delivers a baby. She has pulses that you can feel.
That's really cool. And so you actually have a baby, or I guess a fetus, inside of Lucina that we will be birthing.
Yes, so behind the scenes, we have already loaded a fetus into her abdominal wall, and there is a motor in there that will simulate her birthing the fetus.
That's really cool. I guess what type of other simulations can you run with her? Is it just a typical normal birth, or can you add other things to the mix?
Yes, so we have programs that come in and run simulations with her having normal birth delivery, but she also can have complicated birth delivery. So she can have shoulder dystocia, she can have breech delivery.
Oh, wow.
We do a lot of cases with postpartum hemorrhaging, shock cases, so complications with mom after delivery.
All sorts of things.
Mm-hmm.
That's what, and I guess going back a little bit, like, how do you become a facilitator? Like, how do you get trained to do this type of stuff?
So the nursing program here and the Medical College of Georgia here use Lucina most frequently, and each program have their set of course directors and facilitators, and those are the ones that come in, and then we'll give them some expertise on how to run the mannequin.
Okay.
But nursing faculty and Medical College of Georgia faculty.
Gotcha. All right. So I guess now it's time to run our simulation of Lucina giving birth.
Okay, awesome. So she's controlled by this computer over here. We've already loaded her. She's ready to deliver. So we're going to go ahead and resume her delivery process.
Okay.
So right now, internally, there is a motor that is pushing and causing the contractions for her to deliver the baby. This computer also controls all her vital signs, and
wow.
she has a monitor on the wall where you can view how Lucina is, her stability, her acuity during her contractions and delivery.
Okay.
So the baby's coming. So we're just going to get ready here, and we can see the head is starting to crown.
Okay.
So we're continuing to monitor mom and baby as she delivers. And they're teaching, OBGYN's teaching how to support mom and baby throughout this time. So you can see the baby's head is now crowning. She is ready.
Oh, little baby.
And the baby is here. We're just supporting the delivery. All right, as the instructor, you have to confirm the mechanics over here. And then the baby's here.
Aww.
And we're going to deliver the placenta. And then if you'll place the baby in the warmer.
All right.
And then this is where they can simulate newborn procedures and protocols.
Wow. That's intense. And so then the baby can also, I guess, have its own conditions and, I guess,
Correct.
experiences as well to continue on the training.
So they do a lot of newborn recession protocols in here as well. So they come in and practice what it means to, like, their checklists of everything they need to take care of the infant.
I gotcha. That's really cool. And thank you so much for showing us all the things that go on with Lucina. That is something when I originally thought about becoming a nurse, because once upon a time there was a little boy named Rayshawn who thought nursing was in my career path. Like, I never would have thought about a simulation center. Thank you, Mallory.
Thank you.
All right, y'all, I hope you enjoyed this episode. I certainly did. Never thought I would be able to catch a baby, even if it was a mannequin, in my life. So if you like this episode, you already know what to do. Like, subscribe, do all the things to let us know that you enjoyed it. And if you want to see more stuff like this, let us know that too. Thanks again to Mallory, Dr. AJ, and everyone else that made this episode happen, because doing cool stuff like this is so much fun, but it's super important. So Augusta University is doing so many things to help the maternal health statistics and data change for our state. So stay tuned, because hopefully very soon those numbers will be looking a little greater. And until then, I will see you guys in the next one. Go Jags!